First of all, I would like to thank Professor Sami Alwani, the organizer committee, and of course our head of department, Dr. Osama Abdel Nasir, for this effort and this good scientific meeting. My presentation is about advanced endoscopic sinus surgery. I'm honored to be one member of this old school, medical school, one of the oldest medical school in all Middle East, as Asr Aini Hospital, Cairo University. The advanced endoscopic sinus surgery is transitional zone between endoscopic sinus surgery and skull-base surgery. It includes DCR, dacryocerebral rhinostomy, orbital decompression and transorbital approaches, optic nerve decompression, a pre-lacrimal approach to the maxillary sinus and medial maxillectomy, frontal sinus drainage type 3, graft type 3, and modified approach to reach the lateral part of the frontal sinus, dissection of the pterygopalatine fossa and transpterygoid approaches, transtripiform skull base approaches, and pituitary surgery and carotid dissection. We try to highlight on important items in each of the previously listed item, except the pituitary and the carotid dissection, because it needs a separate lecture, of course, to be discussed. First of all, we're going to start with the DCR. The lacrimal fossa is located between a strong bone anteriorly, it's a frontal process of the maxillary sinus. It's about 3 to 4 millimeter, while posteriorly it's thin lacrimal bone, which is about 1.1 millimeter. This is important because when we try to insert, try to get into the lacrimal bone first, then enlarge anteriorly to the strong bone. It's about 16 millimeter in length and vary in width from 8 to 10 millimeter. If we look here, this is a lacrimal sac. This is the opening of common caniculi. All these items are covered by two important items, which is the ansonate process and middle terminus. So when we insert our endoscope using the 0-degree endoscope, we see this panoramic view of the middle turbinate, its attachment with ansonate process and the depression of the nasolacrimal duct and the upper part of the middle turbinate. Try to fix this view to gain an access to your surgical technique. So first of all, we can have this linear cut in the mucosa, have a posteriorly based flap to uncover the bone. We first remove the agar nasi. The agar nasi are hindering the upper part of the nasolacrimal sac together with the ansonate process. So we do ansonectomy and uncapping of the agar nasi. Then we try to enlarge anteriorly using Carson. We cut through the frontal process of the maxillary bone to have a complete view of the nasolacrimal duct sac. Then we insert our bougie through the lacrimal punctum, through the common caniculi in the upper part. We use a sickle knife to have a vertical cut in the nasolacrimal sac. We use a downward cutting maxillary forceps to enlarge it caudally. Then we insert our flap back in its opening to prevent its reclosure again, taking care to have an excellent view of the drainage of the frontal sinus, not to be closed by our flap. So briefly, this is step-by-step technique in of doing a DCR. So our second item is orbital decompression and transorbital approaches. If we have this view from anterior to posterior in the axial cut, we first have the nasolacrimal duct and nasal bone, then this is lamina papyracea anteriorly, then the part posteriorly, and this is the lateral wall of the sphenoid sinus. So the lamina papyracea from the skull base down to the maxillary sinus. So if we need to have an excellent view of the lamina papyracea, we have to have a wide middle meatal antrostomy proper anterior and posterior sphenoidectomy tells the sphenoid sinus to see the lamina papyracea from anterior to posterior. The important issue is the posterior part of the lamina papyracea is thick, so I may have to drill it over using a diamond pair. But when I reach the anterior part, it's very easy to be removed using ordinary free retractor. I always prefer to have my dissection from posterior to anterior to avoid fat prolapse, which will gonna hinder the view of my field. Then I can cut my orbital periosteum using a micro scissor, so the fat will prolapsing inside the nasal cavity. We can extend the decompression by removing the floor of the orbit through the maxillary sinus, but try to remove a thick bone ridge between the medial orbital floor and medial orbital wall and the floor to avoid prolapsing of the whole globe inside the sinus cavity and consequences in ophthalmos. So again, we're gonna talk about the transorbital approaches. This is a CT of only 1-year-old child with posterior chamber tumor extending to the cavernous sinus. This is the extent of the tumor. So we decide to take a biopsy transorbital. We use an ear instrument because the ordinary nasal instrument is too big to be used in a 1-year-old child. This is the lamina papyracea after doing anterior and posterior sphenoidectomy. We try to remove it, use the round knife of ear instrument. This is the orbital periosteum. We excise the lamina papyracea to tell the optic tubercle posterior. Then we incise orbital periosteum, exposing the medial rectus, and we try to dissect the medial rectus to go inside and exposing the optic nerve and removing a good punch biopsy from the tumor, exposing the optic nerve from inside, and take a sufficient biopsy, and it was a round cell tumor. So let's return back to our list. We talk about DCR, orbital decompression, and transorbital approach. We're gonna now talk about optic nerve decompression. The optic nerve have 4 parts: intracranial part, intracanalicular part, intraorbital part, and small intraocular part. We try to decompress the intracanalicular part. First of all, we should have, as we did in orbital decompression, we have to have middle meatal antrostomy, complete anterior and posterior sphenoidectomy, and wide sphenoidotomy to expose the lateral wall of the sphenoid sinus with the posterior part of the lamina papyracea to exposing the annulus of Zen. The annulus of Zen is formed from fusion of the orbital periosteum together with the dura covering the optic nerve sheath. This is the carotid artery. This is the optic nerve. This is the OCR. This is the annulus of Zen. We cut the orbital periosteum, then go back to the optic nerve. We can use the diamond drill to thin out the covering bone. Then, according to the pathology, we may need to cut the optic nerve sheath, like in this photo, or it is not necessary, just removing the whole covering bone. And the most important issue is to cut the annulus of Zen to have an optic nerve decompression. So we're gonna return and navigate back to our list. We're gonna talk now about the pre-lacrimal approach to the maxillary sinus and medial maxillary. The pre-lacrimal approach is a modification of the classic approach to maxillary sinus. It exposes the whole maxillary sinus, including the anterior wall. We're gonna have a linear incision at the anterior end of the middle turbinate, exposing the nasolacrimal duct. We cut the middle turbinate with the attaching bones using the chisel. We separate the attaching bone of the anterior turbinate from the medial wall of the maxillary to displace them medially. Then we're gonna expose the whole medial wall of the maxillary sinus anterior to the nasolacrimal duct, which was displaced by our inferior turbinate flap. We use our FLIR retractor to go inside the maxillary sinus. We use the carisson to enlarge this ostium anteriorly. Now we're gonna have a wide window exposing the most of the maxillary sinus. If we introduce a curved cannula here, this is the roof of the maxillary sinus, this is the anterior wall of the maxillary sinus, this is the alveolar margins, this is the posterior wall of the maxillary sinus. It's an excellent maneuver to have a complete panoramic view of the maxillary sinus. Don't forget, the bony ridge between the floor of the nose and the maxillary sinus should be drilled out to avoid any consequence osteomyelitis, and try to, when you return back your flap, to cover such a bone. So the floor of the nose is gonna cover this bird bone, and the middle turbinate will be sutured again. So you're gonna have a wide window while the nasal cavity will remain again. This is the PreElectronic Approach with an excellent maneuver to get an excellent view, panoramic view to the whole maxillary sinus. It differs from classic medial maxillectomy that you are drilling only the part which is anterior to the nasolacrimal duct, and you return the whole middle inferior turbinate with its bony attachment back to its place, avoid all the problem of a large nasal cavity. So we can return to our list again. We're gonna talk about the frontal sinus drainage type 3 and the modified approach to the frontal sinus. As my dear brother Hisham give us some tips and tricks about the frontal sinus, the most important thing I want to highlight is before dealing with the frontal sinus, you should take care that you have the proper instrumentation. The frontal sinus differs from any other sinus because you are dealing with the frontal sinus from below. All the bleeding come from upward and you are dealing from below. If you don't have such instrument, don't go inside the frontal sinus. It's easy to have a frontal sinus clearance or draft type 1, but if you wanna do draft type 2A or B or draft 3, you should have one of these instruments. This is a Cobra carisson mushroom, and the most important, and I think it's an intelligent instrument, is Hosmer forceps. It's very nice instrument if you're gonna deal with the frontal sinus. So the draft type 3 is opening 2 frontal sinus after doing 2B in each side, with removing of the whole frontal septation and in cutting of the frontal peak and enlarge from anterior to the posterior till you reach the first olfactory filament. So this is the panoramic view using third-degree instrument. This is the roof of the frontal sinus, this is post frontal sinus, this is the posterior wall, and this video demonstrate a follow-up of a draft type 3. As my brother Sham Lashin said, if you don't remove unnecessary mucosal, it will prevent osteomyelitis and concentric stenosis of your already performed wide ostium. So this is a draft type 3, and we have another modification of this draft type 3 if we need to reach far lateral in our frontal sinus. The first modification is the biportal approach. If we take this case as for an example, we did already, I can here demonstrate the steps of access to the frontal sinus. You should do uncinectomy, exposing the pulla. You will go above the pulla, uncapping of the egg and removing the egg garnizi, then resecting the upper part of the middle turbinate to have a draft type 2B. You're gonna drill out to enlarge the frontal sinus ostium, but the problem here, you have a very narrow anteroposterior diameter. So we have an incision laterally, and we go through this port using our endoscope first to irrigate, and all the fungal come out from our ostium, give us an excellent visualization. And it's not only a port for irrigation and better visualization, but we can use it to insert our instrument through the external port to get an excellent view of the frontal sinus. So we enter our endoscope through the external port. This is the posterior wall of the frontal sinus. This is the anterior wall. We are getting inside the frontal sinus from the external port. So we have two ports to enter the frontal sinus using our endoscope and our instrument. Now we have a clear vision of an empty, cleared frontal sinus, while the normal drainage is still entered. It's an excellent approach to the lateral part of the frontal sinus. It is not only the modified approach. We have a contralateral approach. We can reach the lateral part of the frontal sinus either from contralateral nasal passage through a septectomy to go to the lateral part of the frontal sinus, or if we have something like that, blowout fracture of the orbit and the fat prolapsing and blockage this passage, we can enter the frontal sinus from the contralateral frontal sinus. So the contralateral approach either from contralateral nasal side or from contralateral sinus to go far lateral to the frontal sinus. The last modification is orbital mobilization. You first should identify and recanalize the anterior ethmoidal artery. You identify the anterior ethmoidal artery being in one cell below the frontal sinus ostium. You should cauterize it, have an excellent cauterization. Then you mobilize the orbital preostium and have a very wide exposure to the frontal sinus. All these are modification to access the lateral part of the frontal sinus. So we're gonna have our fifth item is the section of the pterygopalatine fossa and transloid approach. The pterygopalatine fossa is located behind the posterior wall of the maxillary sinus. If you have a wide middle meatal antrostomy exposing the posterior wall of the maxillary sinus, you're going to have the sphenopalatine artery coming through the sphenopalatine foramen. You can use it as a guide to enter to the sphenopalatine pterygopalatine fossa. You remove the whole posterior wall of the maxillary sinus, and in the middle you will shift from pterygopalatine fossa to the infratemporal fossa. You're going to see the foramen rotundum with divisions of maxillary nerve and Vidian canal with the nerve of the pterygoid canal. And you can drill the pterygoid bone here. If we drill this pterygoid, you're going to have an excellent access to all this structure. This is the internal carotid. If you remove all the pterygoid plate, this is the Gasserian ganglia. This is the division V1, V2, V3 of the maxillary sinus. This is the third cranial nerve and sixth cranial nerve, and you can go to the cavernous sinus from here. So the access to the pterygopalatine fossa is important if you are dealing with angiofibroma, of course. And if we further dissect and remove the pterygopalatine fossa content and remove the pterygoid plate, it's an excellent approach to Meckel cave and cavernous sinus. So we're gonna shift to our next topic is transcribiform skull base approach. As mentioned by our dear Professor Oscar, it's if you're gonna have a wide skull base defect before doing any pony work, you should think, how can I close this whole defect? I'm gonna have a defect from skull base anterior to planum sphenoidal posterior. It's a very wide defect. So the first step of your surgery is to harvest that flap, as was mentioned by Dr. Oscar. it's a very good, tough vascularized flap. It is depend on the posterior septal branch of the sphenopalatine artery. If you identify the sphenoid ostium, the sphenopalatine artery pass below the sphenoid ostium. You start to cut your nasal septal flap from the opening of the sphenopalatine foramen upward to the caudal end of the nasal septum. You can extend the Haddad flap down to the floor of the nasal cavity. All this area is depending on this pedicle. You can make more mobilization by removing the sphenoid rostrum. If you remove this bone, you can have an extra length of your Haddad flap. The transcribriform plate, as we saw in the previously demonstrated case, it was an excellent case by Professor Oscar. You make a draft type 3, then you start to separate the cresta galli from the bone, and you cauterize this anterior ethmoidal artery in both sides. Then you start to drill and remove the bone from the anterior ethmoid anterior to the posterior ethmoid. Your approach may be extend backward to the planum, and you're going to have the falx cerebri here and the brain tissue here. Now this is an excellent view of a brain tumor. This is frontal sinus here and frontal sinus here, and the dura and the brain tumor after that. Then you should think of reconstruction, fascia lata, fat, nasoseptal flap, and you can use tissue glue. Then block your nose using gel foam and Mirosil, of course. So this is a brief points about the advanced endoscopic sinus surgery. It's only highlighting a few tracks and taps in each approach. The last is pituitary and carotid dissection. It's very important items because the pituitary surgery is the antrum of all skull-based surgery. If you want to enter from advanced endoscopic sinus surgery and the CSF approach and CSF repair, which was already discussed in the previous lecture, the pituitary surgery is your entrance to the world of skull-based surgery. And after the pituitary surgery, you can do transclival, transplanum, transcribriform, transodontoid. You can reach any part of the skull base from anteriorly to the first vertebrae. And the carotid dissection, of course, it's an excellent way to understand the relation between ear and nose, because you start to dissect the carotid from the middle ear till you enter to the cavernous sinus. So the last two items should be discussed in a separate lecture because they have many steps and tracks and anatomical variation, and you should have a roadmap in your mind to enter such topics. So I hope I can cover all the important items in the previously mentioned topics in the advanced endoscopic sinus surgery, and thank you afterwards.